there might be opportunity for our EVS directors to partner with the OR to help over shoulder some of those competencies. I've been a part of that in the past where I was invited, like, hey, can you come in and observe our team? And, we need to do their annual competencies. And I go in and, we found some good things and we found some things that need to be coached. And so it goes back to that partnership and the availability of the leaders to collaborate. So I'll leave it at that.
Infection stops where information starts. Welcome to the Transmission Control Podcast, where knowledge is your strongest defense. Broadcasting from the front lines of healthcare, we dive into the strategies, science, and stories shaping infection prevention today. Each episode, we connect you with experts on real-world insights to help you stop the spread of healthcare-associated infections, protect patients, and strengthen your practices as an infection prevention and public health expert. When the right information reaches the right people, lives are saved.
Hello and welcome to the Season 4 premiere of the Transmission Control Podcast. My name is Garrett Hollembeak, Editor-in-Chief of Transmission Control, and today we're going to be joined by Mike Epperson, Area Vice President with HHS, to talk about the fine points of collaboration with environmental services. Stay tuned after a brief word from our sponsors.
Brought to you from the studios of Healthcare HQ, let's get into it. This is Transmission Control.
Hello and welcome to Season 4 of the Transmission Control Podcast. My name is Garrett Hollembeak, Editor-in-Chief of Transmission Control, and I'm joined today for the first time as a guest co-host, Trey Morrow. Trey, how are you doing?
I'm doing good. How are you doing?
I'm good, and thank you for joining us. The audience that may not know you or may not be familiar with your work, can you introduce yourself and tell us a little bit about your career in IP?
Well, I kind of had an unconventional start to IP. I was originally an Army medic, and then I was an EMT for a while, worked in a hospital in the ER department. And then I got a bachelor's and kind of looked around and kind of figured, what can I do now? So I progressed, looked around and kind of thought about what I could do. And infection prevention was one of those things that seemed kind of interesting. And the hospital gave me a shot, and I've worked in anywhere from 1,000-bed hospitals to 160-bed hospitals to right now my hospital that I'm at is a 202-bed hospital. I've worked in San Antonio. I've worked in most of my times in San Antonio. I've worked in Florida and Kissimmee, Orlando area.
Nice.
I guess I've been in IP going on about 7 years now. I have 2 master's degrees, and then I have my CIC and my Lean Sigma. So, but I've always enjoyed working with EVS and my EVS partners. So I just kind of really thought
that. And that's a great place to start with this episode because we're going to be joined by Mike Epperson, and we're starting this season where all good patient care starts, and that's with EVS. Everybody knows from either being a patient or having a loved one, when you walk into the hospital room and you see that it's clean, it's well organized, the floors outside of the patient room are clean, that doesn't happen by magic. These are dedicated roles that very talented individuals focus on. And it really becomes a very technical, highly detailed pursuit in infection prevention. And so to talk about that, we have on Mike Epperson today. Mike, how are you doing?
I'm doing good, guys. Thanks for having me on.
Yeah, absolutely. Yeah.
Just a little background on me. I ended up joining the environmental service team about 5 years back, and I never really envisioned myself being in healthcare, let alone environmental services. But, I think introducing myself to the industry and learning, what we really do had impact on me personally from a personal growth standpoint. Just healthcare is so much more than just nurses and doctors. There's so many ancillary support positions, not just housekeeping. We have food and nutrition and radiology and, some of these other departments that really support and prop that up. And then we also have our IP teams. And, so coming from outside industries and my background, a pretty diverse background in different types of industry, getting into the healthcare world was a learning experience for me. One thing that I really leaned on is my relationships. And, I've learned a lot from infection preventionists over the years. And so I think it's, that's what gained my interest in coming on and speaking with y'all today, because I really do have a passion for it. And I've seen, when those relationships are aligned, we can break through barriers and create a clean, safe environment at a whole nother level when we're working together. Whereas if we're not necessarily in the same stride, it can go the opposite way.
And I think that's great. I mean, I think that working with EVS and IP is phenomenal. Just our partnership, it's so important because I feel like y'all are the first people that touch the patient. Like if an environment isn't clean, this is what I always tell my EVS. If the environment isn't clean, our patient's going to get infections. There's just no ifs, ands, or buts about it. And it's not my EVS. It's the EVS departments that I work with, just referencing. But I feel like so many people forget that there's other roles in a hospital besides nursing and doctors. And it's really important to make sure that our EVS is very well taken care of and reminded that they are an important part in this whole machine of the hospital.
Yeah, that's 100% true. And one of the challenges when, just like you said, Trey, when we're working with environmental services and IP, so we're not always speaking the same language. Sometimes there can be a mismatch of expectations or scope. So, Mike, how do we reconcile that, or where do you see the driving forces behind it? I expect EVS to do this. They have this expectation. It was different at my last facility. Why does it change so much?
Yeah, it's a great question. So I've personally experienced where, different scopes of work existed from one facility and even in the same healthcare group, going from one division to the next. And so, I've always really started at what is our scope of work that, being with HHS, we generally have a contractor scope of work, right? And that's clearly defined. But then you start to run into some gray areas, right? Or maybe as I'm rounding a facility, I notice that, keyboards aren't being cleaned.
Yeah.
And, I look at one scope of work on our end and look at a different, and there's definitely a gap. And so, I think, you need to go back to what the guidelines are with the scope of work and the agreement, and then look at what's actually being done in the facility and pull in your stakeholders. I think, a relevant conversation that I've had at the director level was surrounding keyboards.
Oh, yeah. That's a big one.
I had my IP team there, great partners at Ocala. I mean, just a wonderful IP team. Learned a lot. Sometimes we had to have conversations and identify who was responsible for what. And then we're able to partner together and use logic to determine, this is something that EVS needs to cover. We understand that there's a scope, but this is something that we have the right tools to address and we can address it. And so, one of the things with the keyboards, the end result came out like this. We agreed to wipe them down. We're already wiping down all of the area around the nurses' kiosk there. My concern was they weren't all washable keyboards.
Oh, yeah.
And so we then got IT involved and administration involved. And I was like, I'm willing to clean them, but we may damage the keyboards. And so I'm good to go. My team's good to go. But if we're damaging keyboards, who's going to be responsible? And they said, damage all of them. We want them clean or we want them broken. So,
nice.
They made it very simple for us. And so, they may have had to replace a few keyboards with the washable type, but we never got a call about it. And so that was like a great relationship. It was a round table, administration, IP, IT, EVS, and then, we just added that to our things. And, there is always going to be a little bit of scope creep, and that's really with any good partnership. You're going to work together to support each other. But we put that on our actual policy, and that's what we're doing. And so I think it is important to define it. Like if you do have a change in scope, what you're doing that's outside of maybe an original agreement or something that's on paper, and then something that can be passed down to the future director so that there's no confusion, turnover in the management position. People leave and that agreement can sometimes fall apart. And then, IP still thinks EVS is doing it, but EVS doesn't have that information. So it is important that if we start to do that, we make sure that we put that in a documentation form. And generally that's going to come down to like a facility-based policy.
I think that's fantastic. I've had so many times where we've tried to figure out what EVS is actually cleaning. We've had to have so many meetings just going, hey, what are y'all touching versus what does nursing have to touch versus what does dietary have to touch? And we've actually had to sit down and be like, hey, EVS can't clean this. Cause like you said, there's things that y'all can break. And I don't want y'all to break stuff as an IP because unless that's in your contract and they understand that it might, and there's ways to like mitigate it. But like if like what I've had in the past is pumps. I don't know if y'all have had issues with like pumps being cleaned and stuff like that. So EVS typically, at least where I've been, they typically won't clean the inside and won't clean any of that. But nursing thinks that EVS is cleaning it. So we've had to sit down with nursing and go, no, unfortunately, this is not something that EVS is able to clean. It's more in depth.
100%. I mean, the pumps are always a good one. I've seen different scopes of work where EVS was just responsible for the actual IV pull, but not the pump attached. Those agreements typically get changed to where we're doing the IV pull and the exterior of the pump, never the interior. And then you start to run into situations where, maybe you have hanging IV fluids present in the room when we arrive. EVS doesn't touch medication. That's something that I've always held firm on. So if that's in the room, then we have to coordinate with our nursing team. And so, that's a hard stop. We can't really start the process with that in the room. And so that's always the line. And, it comes down to logical reasoning behind that. But, I think it can definitely start to pile up if you're always adding things to your scope of work. And so you have to be strategic with it. You have to use best judgment. And, another one is like a bedside commode. Those can oftentimes be listed as a nursing responsibility, but who has the proper tools to clean that? So how I've handled those, and, again, this can vary by site to site and what the staffing matrix is and other productivity aspects to the job. But the way that we've handled that generally is nursing will make sure that the disposable bucket is dumped and disposed of, but EVS is going to sanitize that actual bedside commode, seat, and frame. And so that's something that makes sense to me, I think, and it makes sense to everyone around in that hospital environment, rather than expecting nursing to use a purple top or an orange top to wipe that down. It just doesn't make sense.
That's something that when I get into a new facility, because I've gone to a few facilities now, the first thing I try to do is look at the contract for EVS, because I feel like each contract's a little different. EVS is expected to do a little bit different, but also there's certain things that they typically can't do. Like obviously the pumps, y'all shouldn't be cleaning those. Y'all should be cleaning the outside unless you're trained to do it. But people expect that. Or like massive blood spills. Like in my contracts, like EVS typically doesn't clean that. Nursing needs to clean it, then EVS will come like sanitize it. So these are discussions that we've had to have with nursing and like letting them know, hey, EVS isn't here to clean per se, here to like sanitize after we've already kind of cleaned.
Yep. That's a perfect one. So, working in trauma facilities, which seems to be where I was at as a director in most of my tenure, trauma bays can be pretty brutal. ORs can be pretty brutal. And so, you put it perfectly. EVS is going to come in and sanitize and disinfect after the bulk of the matter is cleaned up. And, we are trained on blood spill cleans, right? And so there are scenarios, mass casualty events where, we're getting in there, we're just all working together to get it done.
Right. Yeah.
And I've unfortunately been a part of that. And so, there are obviously extremes where you don't want to use that to justify the normal scenario. But, in general, most situations will have either an OR tech clean up the bulk of the matter. You might see residue, you might see smears, but it's not going to be a blood puddle, I guess you could say. The size of a dime drop on the floor is something that EVS would clean. If it starts to become, pancake size or large, you're going to start to really need to get your EMS coordinator involved. Potentially the paramedics are going to be assisting with that in most ER type scenarios. And then in the OR, that would be the ORAs handling kind of the initial cleanup phase. And then that can also kind of lean into other steps of the process. If that happens at the end of the day, then EVS would come in and do the sterilization. If EVS is responsible for in-between case cleans in the OR, then we would go in and do that in-between case clean. But in some cases, the ORAs, or the OR assistants, are responsible for in-between case cleans throughout the day. And so they need to be properly trained on that process as well. So, again, these are great topics because I've seen a lot of engagement from IP and OR, for example. And I've also been in facilities where there was really no engagement on that matter. And they did their own annual competencies. And, it only takes a few SSIs for us to rethink that process. And unfortunately, that's somebody's life that's at stake there. And so, as I've gained experience, these are questions I'm asking when I'm, touring a facility or going in and looking at my terminal clean logs that validate our team's doing what they're supposed to. I'm also asking questions about, the matrix, the makeup, the competencies of those nursing staff. And, there might be opportunity for our EVS directors to partner with the OR to help over shoulder some of those competencies. I've been a part of that in the past where I was invited, like, hey, can you come in and observe our team? And, we need to do their annual competencies. And I go in and, we found some good things and we found some things that need to be coached. And so it goes back to that partnership and the availability of the leaders to collaborate. So I'll leave it at that.
That's a really excellent point too. And each of these cases has, whether it's commodes or large blood spills, they're multifaceted, and you need somebody to kind of pull apart the pieces a little bit, say, all right, who's got the IV pump? Who's got the IV pole? Who's got the internal components? And that's, I think, an opportunity, and maybe, Mike, this has been your experience, for IP to really come in as somebody who can get all of those stakeholders together and then explain the why behind why we have to do this. And then also to advocate for EVS, because it's not fair or ethical to leave an EVS technician in a position of disposing of medication or taking time from their day and then the nurse's day to say, hey, this wasn't disposed of properly, and now I have to stop my workflow. And those are high turnover areas. So this is a real opportunity for IP to advocate for the EVS professional. Now, in terms of advocating and keeping our EVS staff safe, we talk a lot about isolation signage, letting EVS know what's going on in that room. Mike, where have you seen really good examples of that? And maybe you can share some not so great examples of notifying EVS of isolation precautions.
Yeah, great question. That's one that is relevant, I think, for everyone in healthcare. I've personally experienced situations where our housekeeper went into a room and started cleaning, only to, nurses passing by, oh, wait, you need to have PPE on. And they're like, why? There was no sign on the door. And so those are scary scenarios where, it should never happen. But when it does happen, the first process in fixing that is there needs to be immediate escalation. Mm-hmm. I'm used to an incident report type scenario. We need to get details on what type of contact room that was. And, there's potential risk involved with the person that might have been exposed, right? So there's some things that we would immediately do to, take care of that EVS employee who may have potentially been exposed. But the solution can come in a few different ways. Number one, the nurse education process, making sure that those contact precaution signs are never taken down. EVS should be the one taking the sign down, right? But let's just imagine that the sign gets taken down. How can EVS protect themselves with the sign still down, right? Sometimes to reel that back, one other thing would be in our bed watch type programs, for example, there's Cerner, teletracking, bed watch. There's a few other management software programs that EVS uses. Some of them actually do have a contact precaution designated associated to the room.
Right.
So it's not, they're not all perfect. Some of them are tied to like the actual patient's data. So when the patient gets discharged from the system, you lose that information. So I've seen those situations where we actually don't know for a fact what it is. But so let's imagine there's no electronic method. The sign's not on the door. The EVS tech should be trained to look for the signs, right? So, almost always there's going to be some sort of a box hanging on the door, right? For your PP. They're going to see signs in there. So that's the first thing you should start the question, is that there? And then the next thing you should do is use your line of sight and see what's in the trash can. Oftentimes you're going to see isolation gowns. I wish I could say they're always in the trash can, but sometimes they're hanging out.
Half in, half out. Yeah.
Yeah. So, use your visual cues before you approach. And if you're wondering, suspicious, then you should probably stop and go ask. And so those types of processes have saved, a lot of individuals from potentially going in the room. But this happened a few times. I'm not going to name facilities. Awesome nursing staff. Someone made a mistake, right? And so my team escalated. Housekeeper escalates to supervisor to manager to me, and then we have a follow-up conversation the next day. Like, how can we prevent this from happening? And I think it starts with the education, starts in orientation, like really aligning with how that process needs to work. And then also continual education with, whether it's in like a health stream format or monthly testing, nursing colleagues are all doing these things as well as EVS, but also like just my touch point as a director, what we like to go up and do in services at the unit level. Sometimes it's about linen utilization. Sometimes it's about, myriad of topics, but making sure that we're continually having this as a touch point and bringing it up. And when it does happen, sharing where the failure was and, what could have been done to prevent it. So it's just consistent awareness around it.
I love that. I mean, I feel like what's the education style like for like EVS and isolation signs? I have to be honest with you. Every now and then I have to re-educate EVS and be like, hey man, this is what this sign really means. Let's make sure that we're doing it correctly. Do you know if what would be an ideal program for you to where you're like teaching them about these isolation signs? How can IP help you with this is mainly what I'm getting at. Yeah,
great question. So, I wish every education program was something that everyone retained, but HHS does have, monthly team member testing, we call it, but it's really video, educational videos. They're interactive. And so you click this bot, you have to answer questions at the end, and it's a pass or fail, right? So that is, ongoing education that helps keep our teams confident in all the different areas that we touch through the facility. But typically the retainment from educational video is pretty low. Like we know, you go through a program, you go through your orientation, and, 30 days later, you've retained 25% of what you learned, right? So it goes back to continual education. I think the best thing that I've seen, like boots on the ground, this was a real issue at one of my facilities. And so I talked with my managers, and my manager actually had a great idea. His name's Pablo, and I give him a shout out because he sees this. Pablo had a great idea. He said, I'm going to squash this. We're going to eliminate the confusion. We actually have a safety board at each of our facilities. And so, every morning we have a huddle. It's just like 5 to 7 minute huddle, just like high-low topics, safety discussion. We do, uniform and shoes compliance checks. And we want to make sure everybody's ready to go have a good day and be safe. But in those huddles, we actually went and partnered with our IP team. We got a copy of every single isolation sign imaginable. And we literally used them as a picture frame around the huddle board. And so all the different ones. And then next to each one, we actually, pinned the tail of the donkey, of the PPE associated with each one.
Awesome.
And so we could do like a rotating conversation topic, what's the red square with the brown in the middle? That was for C. diff specifically. So, and then going through the 2-step cleaning process where we're going in and sanitizing everything, and then we're going back through and bleaching everything. And so, these topics take constant repetition, talking about dwell times, talking about safety data sheets, talking about why it requires bleach to kill C. diff, right? Versus, why doesn't, Oxivir or Virex kill C. diff when bleach does, right? And so helping the team understand it, I think, is like the aha moment, and constantly staying on it. So, safety isn't an accident right? Safety is intentional. We have to be consistent with it and continue the education. And you have to be engaged as leaders. You can't just assume that people are going to watch the video and retain it.
Yeah, it's really that need for like multiple ways to learn the same thing over and over and over. One of my favorite things to think about is people need to be reminded more than they need to be taught. And that applies there with pin the tail on the isolation sign. And that's a good opportunity for IP to go in and say, hey, this is what happens if we have to do a tracer for a patient who is TB positive. And those are always kind of dicey situations because EVS can get left out of the loop on those. And it just puts everybody at greater risk, especially the frontline staff. As we kind of round on the end of this episode, when we talk about IP doing audits and rounding and really supporting EVS, what are some kind of high-level things that IP should pay attention to, whether they're looking at a room turnover or the EVS cart? What are some common things you see out there?
Oh, man, where do I start? I would say one of the big opportunities, I think, is, standard cart setup, understanding what you should see in those carts as an IP. The goal is that we have the proper chemicals, the proper safety data sheets, and the proper tools in the cart. And if we don't have those, then how can we do the job? And I think, one that's been brought up to me in the past was high dusters, right? How are we high dusting if the housekeeper doesn't have a high duster on the cart? I had to go deal with that. So, just being understanding of what the tools are. And then when you're rounding, keeping your eyes open to that, looking at, cross-contamination opportunities and continual education. So, we don't allow drinks in the nurse's station. They shouldn't be in the housekeeping cart, right? The same principles of like paper, chemicals, they don't mix, right? So housekeeping carts can have a myriad of different options in there. The way we've really always trained it is those items, like if you have paper towels, those should be in a plastic bag tied off in a gooseneck knot until you're ready to use it, right? So if you have those just loose leaf thrown in the cart, I consider the housekeeping cart technically dirty. Like, I know it's clean the cart, but like I'm treating it as if I've got to protect my product from it. Obviously, it's got to be sanitized and cleaned. In a perfect world, it's supposed to be sanitized and cleaned consistently through, at the pass off from shift to shift and things like that. But as a housekeeper, I have to understand that as I'm working with that cart, I could recontaminate it, and so I need to protect that stuff. So, for IP, looking at the carts, looking at what's in the cart potentially, and then really when you're maybe over the shouldering or doing a tracer, observing a housekeeper clean, I think the biggest area where it's easy for contamination to occur is just between the different steps that we use to clean the room and not changing gloves or not sanitizing, gel in, gel out. As I would say, for just your general patient safety, the step where we go from the patient room to the restroom, it's critical that we're doing that in the right order. And I don't know what it is, but there's something with human nature where people want to clean the bathroom first. Like, and if you let that routine take root and you're not up consistently doing your over the shoulders and your audits to validate and visualize the process, for whatever reason, sometimes those bad habits can creep back in. And so, keeping those areas separate, God forbid it's in a semi-private room, right? And so, we have to treat every patient as if maybe one person has something we don't know about. And so, if we're taking our job seriously, we should be keeping that in mind. And so as an IP infection preventionist, when you're rounding, just be eyes open on that and just don't be afraid to engage and educate. I would say it's more impactful. Some of the more impactful conversations that my housekeepers have had over the years came from IP, and they were like, whoa, they were like shocked that IP had stopped and engaged with them, because it seemed like they knew who IP is, but they didn't feel like they were there for us. They felt like it was more like nursing and IP, and they're checking tubes or, drains and things like that. So, those are some good ones. There's a lot more, but I think those are probably the most relevant, like the day to day.
I like that. I mean, I feel like working with EVS all the time, just like you said, going from the bath, because I audit EVS quite a lot because I love dealing with EVS and helping EVS. Going from the bathroom to cleaning the bed it's one of the things that I struggle with trying to negate as much as I can with IP and with the director. One of the things that I've kind of started doing in some of the places that I've had is putting the VeriClean spray and stuff like that. So I'll spray it down after everything's done to make sure that they're hitting everything. So I feel like these audits are super important, and they're important to help teach, not just EVS. When I first started, I thought that I was trying to catch them doing things, but it's not trying to catch them. My whole role is to make sure that we're getting the things so that we can educate. Like, I wanted to make sure, hey, we're not getting these bed rails. We're not getting these doorknobs. We're not getting these, whatever it is. Just so that we can help keep our patients safe. And I feel like these audits are important. Going to the cart setup. So I had EVS putting their microfiber cloths into the quant, and it was quant binding, which is something that I still don't think a lot of IPs really understand too much. Like, you have to make sure that if you're using quant in your facility, you have to make sure that your microfibers isn't sitting in the solution, because it dilutes it so much, and eventually all you're going to be doing is cleaning with water.
Yep. You can run into a lot of different things. Like, I'm familiar with Diversey disinfectant solutions. And so, I don't know if everyone knows this, but Virex after 24 hours is basically worthless. And so, those morning cart checks, pretty important. Like, I can, EVS stuff, but,
you get the feel.
But, if you see someone, they're bringing in a cart and it has, a bucket of half-used solution from the day before, then we should be making sure that that's getting properly disposed of. Something I was going to touch on with the UV light and the UV testing, that is such a critical tool. And so, I'll be honest, my first director role, I felt a little defensive. I felt like IP might be out to get me on that. And so we had to kind of go through the throes of me taking embarrassments, quite frankly. So what I learned is, number one, the team's never as good as you think they are, even if you have a great team. There's always education to go around. Number two, if we don't communicate, we don't know, right? So I had to partner with my IP leader at the time to help him understand when to place the marks, because they were going up and just blindly placing the marks, and they were placing marks sometimes on rooms that we already cleaned for the day, and then coming back and checking the next morning before we cleaned it the next day. And so, of course, that mark's going to still be there, and I'm going to get a 0, right? So I showed them how to educate themselves by looking at the job sheet and seeing where the housekeeper had been, marking the non-cleaned rooms, or waiting for us to clean the room and marking it after that. And then the next day when you come back, making sure it's actually been cleaned before you test the mark. So that's one thing that I had to, help them understand. And then my learning experience was, the goal of this isn't I got you, right? It's not I got you, you're not doing your job. It's, we need a clean, safe environment. So I actually got some of the spray, I got some of the UV, the UV light, the UV spray, very clean. And I started using as training with my team. And I would do exhibition runs, right? And I would show them, hey, I marked your unit. You're not getting graded on this, but let's imagine that we weren't doing this training. How many sink handles would be contaminated after the cleans? I actually take the housekeeper in and show them with the light, like, hey, these are the areas that are most important. This is the part of our cleaning process. So once we really did that, we took the resistance away, the human nature of I'm getting caught, to I need to focus on these items. And so I use it as a training tool to where, yes, there was still opportunity, but it produced a much better result to collaborate, use it as a training tool, and embrace the process and understand why the process is there. And then help our team understand, because they, housekeepers can get very defensive and concerned, and, really bringing that education in and helping them understand, having IP come to our huddles and educate and be a part of that process.
And I think that's great. I mean, I love talking with the EVS about these types of things. And it's funny because I don't know, Garrett, I don't know if you've noticed it, but when you start talking with the EVS as an IP, they'll start telling you everything around the hospital.
Yeah. I just divulge all the secrets.
They'll tell you the secrets. They'll tell you who's not wearing PPE. Like, I love my EVS folks. And now they come to me and they're like, hey, just so you know, I didn't clean this room, but I noticed that this was still in there. And I'm like, it's okay. It's not on you. We just need to make sure we clean it for the patient.
That's such a great point. And it's these kind of, I'll say, fine details of collaboration between IP and EVS that makes the patient safer. Not every patient that comes in is going to get a central line or a catheter. every patient that comes in the hospital is going to be affected by the quality of environmental services. So, Mike, we want to thank you for your expertise and giving us really the fine details of how to collaborate with EVS and for your work keeping patients safe out there. We appreciate it.
You got it. Thank you, guys.
Oh man, that was such a great episode. I love working with EVS, and just hearing their point of view, because a lot of times as an IP, we feel like we're just kind of working with them and we don't really get to hear their point of view. We don't get to hear their side of the story. And I like to get involved. And I love, like I said, I love when EVS finally comes to me and starts telling me things. And I loved how he talked about just room cleaning and like auditing those rooms, because I feel like that's just so important, especially as an IP with EVS.
It really is. And one of my favorite things in that conversation was that immediate escalation. That if an EVS staff member is put at risk because an isolation sign was taken down or that communication didn't occur, that's really something to escalate, to follow up on. And that goes right in line with what Mike was saying about, as an IP, keep your eyes open. Don't be afraid to educate. I think sometimes we worry too much about like making staff feel nervous or like it's a gotcha moment, but really staff, especially in the healthcare setting, loves information. And that's going to be a through line for this season. As we said on last season, as we'll say all of season 4, infection stops where information starts. Thanks for joining us and stay tuned for the next episode.
Thanks for tuning in to the Transmission Control Podcast, where infection stops because information starts. If you enjoyed this episode, let us know. Connect with us on LinkedIn, Facebook, or wherever you get your podcasts. Don't forget to leave a 5-star rating and share this episode with your team. Until next time, stay informed, stay vigilant, and keep transmission under control.